Very much.
Thank you to the organizer for selecting our presentation. Okay, so therapy-related myeloid neoplasm are classified by WHO and include myelodysplastic syndrome, acute myeloid leukemias, and MDS, MPN in those patients treated with cytotoxic therapy for a primary neoplasm or an autoimmune disease. The mostly represented primary cancers are lymphoid disorders, breast and genitourinary, and myeloma. And the median latency time from primary diagnosis to TMN is long, usually is over 4 years. The antineoplastic agents that are mostly involved in the therapy for the prior cancer are alkylating agents, topoisomerase II inhibitors, antitubulin, and antimetabolites. And interestingly, some of them are linked to specific genetic lesions. Going deeper into genetics, 60%, more than 60% of TMNs harbor an abnormal karyotype with an enrichment in poor risk complex or all or partial losses of chromosome 5 and 7 as compared to the de novo counterpart. As to mutational status, we found in TMDS an enrichment in TP53, PPM1D, ZBB1, and in TML as well an enrichment in TP53 and splicing factors, and a reduction in incidence of those genetic lesions like NPM1 and FLT3, which were represented in the de novo counterpart. Historical data confer poor prognosis to TMNs. However, not all TMNs behave similarly. In fact, we know that therapy-related CBF leukemias or PMR rara have shown similar outcome as compared to the de novo counterpart. Some prognostic tools that we use for de novo MDS, like EPSSR, MD Anderson prognostic score, or EPSSM, are able to stratify TMDS in discrete categories with different prognosis. In our work, we focus on TMNs secondary to multiple myeloma, a disease which has faced in the last year dramatic advance in the therapeutic armamentarium, especially with the introduction of immunomodulatory drugs and proteasome inhibitors. According to registry with data collected until 2012, the incidence of TMN in myeloma patients ranges between 1% and 3%. As to the pathogenesis, this recapitulates the pathogenesis of all TMNs with specific patient-related, disease-related and genetic-related factor like acquired CHIP or hereditary cancer syndrome. And of course, a fundamental role is that of the myeloma-directed therapy, in particular alkylating agents and immunomodulators, or also the autostem cell procedure. What we know is that TMNs generally have a poor outcome, that the combination of chemotherapy, including melphalan or also cyclophosphamide, correlates with complex karyotype or also alteration in chromosome 5 and 7, and that also lenalidomide has been linked to the genesis of hematologic second malignancies, especially when combined with alkylators, and that CHIP and also low level of mutation of TP53 present before autologous stem cell transplantation might represent a predisposing factor. The objective of our study was to investigate the prevalence and clinical biological characteristics of therapy-related myeloid neoplasm developing after therapy for multiple myeloma, especially in focusing on those patients treated with first and or second generation IMiDs or proteasome inhibitors. The study was conducted with a joint effort of the Gruppo Myeloma Lazio and Gruppo Laziale Myelodysplasie, and within more than 2,500 myeloma patients included in the registry between 2011 and 2018, we identified 20 TMNs. At the time of myeloma diagnosis, the median age of patients was 55 years. 4 patients, so 20% of patients, had prior history of cancer and 10% had familiar history of hematologic cancer. The majority were males and were EGG or EGA myeloma, and only 4 out of 20 patients carried karyotype abnormalities. As to treatments, all but 1 patient were treated with regimens including proteasome inhibitors of IMiDs frontline. 14 underwent autologous stem cell transplantation, and those patients were maintained with continuous lenalidomide. 6 patients relapsed before TMN and were treated with novel combinations including daratumumab and carfilzomib. At the time of myeloma TMN diagnosis, the status of myeloma was 55% between very good partial remission and CR, and 45% of patients were in partial remission. At the time of TMN, the median age was 64, and the time to TMN was median time to TMN was 51 months. 3 patients had TML, and 17 patients had TMDS, with 6 characterized by blast excess, 7 single lineage dysplasia, and 4 multilineage dysplasia. As to karyotype, we found that 66% harbored an abnormal karyotype with 50% between complex and poor risk, and 50% harboring either a normal karyotype or a good risk karyotype. When stratifying patients with prognosis, we found an enrichment in low and very low risk according to EPSSR, which is higher than what reported in one of the largest series most recently published. As to treatment, TML patients, of the 3 TML patients, 1 experienced early death, 1 was treated with Vyxeos but experienced ML progression, the other 1 was treated with decitabine and venetoclax and experienced CR but died unfortunately for progressive myeloma. Of the 6 high-risk patients with MDS, all were treated with azacitidine. 2 underwent allogenic stem cell transplantation but died due to transplant complication, and 4 did not undergo stem cell transplantation. Of these, 1 died due to infection. The majority of very low and low-risk EPSSR patients underwent treatment with ASAS. And with a median follow-up of 30 months, this is the survival of all TMNs, which is around which exceeds 50%. The cause of this, when we split between low-risk TMNs and high-risk TMNs, we found an important difference. In fact, low risk, including intermediate, low, or very low risk, according to EPSSR, had a significantly higher survival as compared to high-risk disease, so adverse risk ELN for AML, or high-risk and very high-risk for MDS. And those patients with high-risk disease harbored a significantly poorer prognosis. We are now implementing the mutational analysis. I just reported the 1 case for which we have results. This patient has been treated with PAD and Veldex and underwent 2 autologous stem cell transplantation and lenalidomide and dexamethasone. In this case, what we found was that the patient at the time of the TMN had a normal karyotype and harbored a mutation in TP53, CBPA, and DNMT3A. And also WT1 at a lower VAF of variant allele frequency of 4%. We are now going back to track the mutations in the previous samples. So in conclusion, we can say that although rare, TMNs after multiple myeloma still represent a complication, also in the area of IMiDs and proteasome inhibitors, that we found in our study a high rate of very low and low risk TMDS patients with harbor a more favorable outcome, so deserve a separate treatment as compared to high-risk disease. That therapy with hypomethylating agents was the most used in our series, but the addition of new agents might improve the outcomes. And that said, future plans we're now implementing in the mutational studies to investigate NGS samples of TMN and study sequential samples when these are available. And with this, I thank you and thank all the people that collaborated to this project.